Thanks, everyone. I would like to begin by acknowledging the traditional owners of the land which we're meeting today, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present, and emerging. I would also like to acknowledge the traditional owners and custodians of the land which this research was carried out, the Yolngu people of North East Arnhem Land. So I was involved in this project with Professor Beverly Ann Biggs, who's the PI of the project, to evaluate the Hope for Health program. So I'll start off by presenting some of the results and then hand over to Tim, who is the co-founder of the Hope for Health program. So by way of a background, North East Arnhem Land is home to one of the oldest continuously living cultures in the world. Home to the Yolngu people, one of the largest Indigenous groups in Australia. So Indigenous Australians living in remote communities often hold a deep and historic connection to that country and often still maintain complex and ancient systems of law and knowledge. However, most recently, North East Arnhem Land have had the highest rates of avoidable deaths across Australia. And this is seen here in blue, which is predominantly due to chronic diseases such as cardiovascular disease and diabetes. And we know that in remote areas in Indigenous Australia, Indigenous Australians are more than 5 times as likely as non-Indigenous people to have diabetes. And local health services and other programs have really attempted to address this issue, but efforts so far have had limited success. So one of the components of the burden of chronic disease is largely due to diets high in processed modern foods. So this is a study from 2013 evaluating or understanding purchasing of foods at the local stores. So what we can see in remote communities is that carbohydrates are at the high end of the mainstream recommendations, just over 60%, which are derived largely from bread, flour, or other refined products, notably lots of sugar-sweetened beverages. We can also see that the diet is low in protein, exceedingly so compared to a traditional diet, and of poor quality, primarily derived from breads and flour. Fat intake were within the mainstream recommendations, as were saturated fat. However, what this study also showed was total calorie intake is quite excessive in this population. That it was about 1,200 kilojoules over the recommended daily intake. So this is roughly eating 1 extra day of food per week. So we really needed to find culturally appropriate programs for the prevention of chronic disease in remote communities in Arnhem Land. So the Hope for Health program is a grassroots program that has been running intermittently in remote North East Arnhem Land since 2015. It's a lifestyle and dietary program developed by a number of Yolngu elders together with non-Aboriginal professionals. So program oversight includes senior Yolngu community members and incorporates traditional knowledge and practices with Western knowledge and approaches to health, nutrition, and lifestyle. So in 2022, we, for the Hope for Health program, which was delivered over 4 months, so all participants received health coaching sessions that involved reviewing their results from initial health checks, the meaning of test results, educational videos about chronic disease, and discussion around good food and goal setting. Individuals also chose to participate in an immersive 12-day bush retreat. So this was focusing on experiencing good health, reconnecting with Yolngu tradition of living, eating, and healing from the land. Participants were also provided with in-community support and mentoring. So this occurred after the retreat for about 14 weeks. So this included group activities such as cooking classes, identifying healthy food options at the store, storing and cooking fresh produce. So this is, in terms of evaluating the program, the study design was a prospective pre-post study. And the primary outcome was a reduction in weight of at least 5% from baseline in 10% of the program participants. And secondary outcomes included improvement in key metabolic health indicators at program end. So this is just a flow diagram of the study. So we recruited participants, adults 18 to 65 years of age who were overweight or obese. 66 participants entered the program, and of these, we included 55 of these participants in our final analysis. So just moving on to clinical outcomes of the program. So the 4-month Hope for Health program was associated with the reduced cardiometabolic risk factors in this population, with a weight loss of at least 5% achieved by 18% of the participants. Other key metabolic health indicators improved, including a decreased waist circumference, BMI, HbA1c, and LDL cholesterol. And we also saw an increase in HDL cholesterol. More strikingly, we saw that more than half of the participants showed a clinically significant reduction in HbA1c at program end. So this was a 0.3% reduction in HbA1c. And many of the participants did overall manage to reduce their HbA1c levels as well as weight. We also looked at physical activity and diet pre-post program. So we measured physical activity objectively using a activity monitor. That showed that walking and moderate to vigorous physical activity increased by a median of more than 100 minutes a day from baseline to endline. We also looked at dietary intake through questionnaires, and this showed that intake of bread, cereal, and sugar-sweetened beverages reduced, and meat intake increased in those completing the baseline questionnaires. And this is in line with the Hope for Health program's dietary education, which Tim will expand on a bit later. So collectively, this was the largest comprehensive study in a remote community to look at a culturally appropriate program for the prevention of chronic disease. And what we see is that the Hope for Health program was associated with clinically significant and favorable changes in cardiometabolic risk factors. With this, there is a great need to embed the successful elements of the program within community through collaborations and stakeholders to improve health outcomes in these remote communities. So next up, I'll hand over to Tim. So very briefly, Tim's been working in East Arnhem for about more than 22 years. He has a very strong connection to North East Arnhem Land, and he is an anthropologist who's been working across Arnhem Land, working with the Yolngu people to develop the Hope for Health program.
Thanks, Hasthi, and a lot of thanks needs to go to Melbourne Uni and Professor Bev Biggs for making this evaluation of the Hope for Health program happen. As you just saw in the data there, we got some really great outcomes, and what those associations really indicate is the effectiveness of the education, which is based on a traditional diet framework. The traditional diet is low carb. So it's the low carb framework that's being used in the education to help people understand what good food is. I also just need to recognise the Aboriginal women that I work with in Elcho Island. The committee has been key in designing this program throughout, through a co-design, culturally appropriate process. They speak an Indigenous language, and English is their third or fourth language. So being here today would be extremely difficult for them to present in the time frame that's available. So that responsibility falls to me, being the one who has been key, central in putting all the education together. In the data, people are making incremental changes, and that is being achieved over 3 months. And for most people, about half of those 55 participants, they're not getting any more than a single consultation, which includes 40 minutes of an educational video in language. So it's not an intense intervention, but yet we've still seen really dramatic changes. Of course, individuals can achieve greater than the average change. And in the past, we have run programs that have been able to be sustained over longer periods of time, 6 or 12 months. And this was one of our early programs in 2015, where we saw some really brilliant outcomes amongst our diabetics who, and they had goals to reduce their medications or even to achieve remission, and about half of them got very close to or achieved that goal, getting into well-controlled blood sugar territory. It's important to note that the program is not about telling people what to eat. That's an assumption that's sometimes made about the best approach to supporting Indigenous people in health change. The program provides them with an understanding of what good food is and what is going on in their body when they eat that food. So what we try to do is build on the existing framework that they have, culturally and historically, and then provide the detailed information in their language about how to understand the diseases that they're facing. The traditional diet in the literature shows very clearly that it's a very low-carb diet. Generally, the figure for energy intake of carbohydrates is around 10%. It's also considered a very high-protein diet, and I think, personally, I think that those figures may be a little exaggerated, but they record about 40% to 50%, and fat intake at around 20%. Again, I think when you see the framework that Aboriginal people are working from, I think that suggests that those figures may be a little skewy, probably to do with the conditions that the studies were done in. It's a animal-based diet, but with significant plant food, significant intake of plant foods. But more important than the macros is actually what is the dietary framework that Indigenous people are using. It might be a funny way to think about it, but I like to think about it as the Yolngu people had dietary guidelines. So what I'm presenting here in a way is a way of understanding traditional dietary guidelines. It wasn't just the case that they were eating randomly. They would teach their kids, and they would have ways integrated into their culture as to how they should eat. But to understand that, first of all, we have to understand the traditional food groups. The first food group is matayal, which is protein-rich foods. Now, these are all meats. So that's fairly easy for us to understand. Now, meat quality is determined by the availability of fat in that animal to be eaten with the protein. Munyangata, or munyang, is carbohydrate foods. So these are plant foods, but the Yolngu people are not thinking in terms of animal and plant when they're thinking about the food. They're thinking about the way it affects the body. And these food groups include the modern foods. So they've been used to understand modern foods. So carbohydrate-based products like grains and sugars are considered part of the munyang, the carbohydrate foods in Arnhem Land. So we've unpacked the traditional framework by kind of organising it into a group of rules. It's not the way that the Yolngu people would think about it, as to have a list of rules. These things are embedded in the culture, are expectations that are lived out and communicated in the process of life. So I'm just going to go through them quickly and then we'll come back to their relevance. So first of all, food is holy, it's duyu. It's highly respected and it's integrated into the law. Mel manapanluki, eat a variety of foods. You don't just go out and get the same foods every day, even if it's in season. You want to have a variety from both of those food groups, the protein-rich and the carbohydrate foods. Wurungoloki mataya. So first eat protein-rich foods until you're satiated or satisfied, and then eat from the carbohydrate foods to bukabright in a row, which means to quicken the body, to have that energy hit. And that the Yolngu people are very sensitive to what their body is doing. So even these low GI foods that they ate traditionally, they still sense the impact of those carbohydrates on their body. The foods are harvested according to the season, and one of the reasons for that seasonal aspect is they're going to eat their animal foods when the fat content in the animal is at the highest. And things like stingray and shark, they will actually look at the liver before they eat it. And if there's not enough fat there, they actually won't eat it unless they're particularly hungry, because they don't want to put the effort into a lean protein source. Now, mainstream education today in Aboriginal communities is based on the Australian Dietary Guidelines, with the exception of the Hope for Health program, as far as I know. I know there's some other studies there's some other interventions that are low carb based in other parts of Australia, but in the remote communities of Northern Australia, that's not the case. And there's a number of problems with the high carbohydrate model for controlling chronic disease, apart from some of the ones you've already heard about and we'll hear more about today. Aboriginal people find it very difficult to follow this diet because it requires you to manage calorie intake. It requires you to be very disciplined in regard to your hunger, where you might have to eat serving sizes that are less than what you actually feel like eating. People also don't eat regular meals. They eat meals at all kinds of different times through the day, and they often don't plate it up. So when you present to them something like this that suggests certain serving sizes for different types of food on a plate, they just don't have a plate to assess that. Also, the demonising of natural fats causes a problem. It creates a lot of confusion for people, and I'll come back to that later. So the traditional diet and the low-carb diet has some really great advantages for teaching Aboriginal people what good food is. And really the place to start is the people's view of food in general. And one of the things that causes confusion is that traditional Aboriginal people groups look at food as being holy, something that should be respected. The animal foods, the plant foods, the land and the people themselves are all seen as integrated, and this is encoded in their own law, including in property rights, like land rights. And so when they see the food in the store, food that is created by Western society, which they see as being a very sophisticated, intelligent, scientifically based society, the question that arises is, how could these foods be bad for you? So when you're told that these foods are causing the diseases that you're suffering from that have arisen since colonisation, it simply does not make sense to people. What we have to help people understand is actually the commercialisation of food. And you'll come to the realisation that Balanda, that is Western society, has lost its sense of the holiness of foods, the sacredness of natural foods. And that might be a bit hard to understand, but many of us here would recognise the sacredness of foods, and we could think about it in terms of evolutionary terms, where we are adapted to our natural environment. There is a fit that needs to be respected. And it is very helpful for people to understand that the fit with natural foods is not being respected in the commercialisation of foods, and the desire to create palatable, long shelf life, saleable items. This story also helps people to understand the difference between processed and natural foods, because that's not embedded in their existing culture or their language. It's something that we understand very naturally, having grown up with it. But to understand that a packaged food item is nutritionally different from a natural food item is simply just not on the radar for our Indigenous Yolngu people until this is worked through. Now, of course, their rules suggest you eat a variety of foods, but more importantly is how do you know how much you're going to eat? Now, the traditional framework explains this. First, you eat protein-rich foods, and then you eat the carbohydrate foods. And you eat the protein-rich foods until you feel satisfied. And this is not just the case of what you do within a meal. This is about the prioritisation of protein foods. And what's really interesting is that modern science has really only just become to understand why this is useful. Particularly the work of Rabenheimer and Simpson, they came up with the concept of protein leveraging. And this is where organisms, including humans, have a protein target that we unconsciously eat towards. So what that means is when we eat enough protein for what the organism desires, our desire for more calories is limited. When we don't get enough protein for the organism's target, then we overeat calories until we hit that protein target. And this, of course, is what you see happening in Aboriginal communities where people are relying on carbohydrate-based refined foods, and they're not quite getting their protein target, and they're getting most of their protein from these carbohydrate sources with very large calorie intakes. So what we've found that when people do eat in this way, they're less likely to overeat, particularly, of course, if they move away from those refined foods. And there may be a need to, if they can't move away from the refined foods for the many economic and other social reasons that occur in community, there is a need to give them a sense of what is a good serving size to go with that protein or after that protein. The challenges are Indigenous communities quite complex. Things like not having fridges, things like not having access to money every day in a fortnight, demand from other family members and who has control of the person who does the shopping. So there's all these very complex solutions that we can't solve ourselves. We can't solve as practitioners looking in, or as educators looking in, telling people what they should eat. So it's very important that they have a framework they can use to solve those problems themselves. And I'd like to just briefly mention the challenge of helping people understand the role of fat, because the mainstream education tends to just say, avoid it. There is, as you would see elsewhere, there is quite a fear of low carb, meaning people eat too much saturated fat. But one of the big issues in community is when you demonize fat, you create a confusion in people about, you've created distrust in the education. For example, if I was to go to Arnhem Land and talk to someone who hadn't been through the Hope for Health program and ask them what is good food, if you go to the shop, what is good food? They would come up with an answer to simplify, something like, it's muckin. So muckin is a word that means without sweetness, without fat, tasteless. This is their picture of what mainstream education is selling them. Dry biscuits, damper without anything on it, plain bread, and in a way that's what some of them are eating. It's not a very palatable message, and so it's not trusted, because the Indigenous food, which is very rich and tasty, shouldn't be better than the Ballanda food, surely. The whitefella food should be more sophisticated and good for you, right? So when we demonise fat, we send a culturally inappropriate message that actually causes confusion. And this doesn't need to be the case, because even if people increase their meat intakes and their natural fat intake from meats, they're not actually just getting saturated fat. I've noted that many people working in health in Aboriginal communities don't realise that, even in beef, you can have 40% of that being unsaturated. And beef, for an example, actually has a better omega-6 to 3 ratio than kangaroo, which was surprising for me. So by eating these animal meats and so aligning with the traditional diet, they're actually getting a very, very balanced intake of fats and some potential improvements in our inflammation. So that's where I'm going to conclude today. And the main overall message that I want you to hear is that using a traditional dietary framework for education, a low-carb framework, this enables people to self-manage health improvement. And that's what I need to say. So thank you all.